And I asked that question, obviously, there's skeptics out there because with this treatment, you're still drinking. And, really speaking to loved ones of those who are considering the Sinclair method or who are using it, what might you say to them, if they don't quite understand this? Or the common thing I hear is, oh, it's just an excuse for them to keep drinking. Like, I want them to just quit drinking today. What would you say to a loved one who's in that place? And granted, I want to honor where they're at as well, because if you're a loved one, typically there's been a lot of pain, turmoil, just difficulty helping someone who has alcohol use disorder. So I'm just curious, how do you talk with or support or explain this method to those people?
Yeah, that's right. A lot of trust has been broken, often in the case, or the relationship can be damaged, and the person, could say the non-drinker will say, is at their wits' end, or they really have had enough. So they are just kind of you can understand their position as well in terms of just their frustration and they're kind of maybe they've seen treatment not work, or go in to a 30-day program and then the person's drinking again within several days. So there's aspect of it. I mean, I think I can really appreciate the position of that person, and kind of the frustration and why they would need to kind of have this explained to them in a particular way. And I think, one of the things that is helpful in those situations, one is just to have the person involved with the appointment. For example, I invite, I want as many people as used to be at the office as my couch would hold, or as now it's their couch, maybe in their living room. But I think that's really one of the main things, is because if there is trust broken, it could be hard to believe that they are still allowed to drink, or something like that. That it might just sound like that kind of hearing the Sinclair method kind of a secondhand, it might not be so convincing. So I think just having an appointment with the provider, and just, in my case, me kind of saying, yes, that is correct, this is how it works, and da-da-da. And the other thing I like to do is the Sinclair method. And it's interesting, they didn't call it the Sinclair method, but it was the Sinclair method. It was featured on NBC News a few years ago, and they did kind of like a 10-minute piece on it. So I like to provide kind of, NBC News has a certain stature to it. It's kind of a brand that has some weight to it. And it's also short. It's shorter than One Little Pill, which is another good thing to watch, but that is kind of a more investment. This is about a 10-minute video. And there are a couple of physicians on there kind of explaining the rationale for it, and just kind of seeing it on someplace like NBC News adds a little bit of credibility to it. So that's the other thing I do, is say, please just watch this 10-minute video on NBC News, and that can often be very helpful. But I think once you explain that that it is just a basic system of reward, and taking away the reward, and why it's important that you still have the behavior going on while you're not being rewarded. I think that that's key. But I will say, in the kind of the non-drinker's defense, it really is hard to explain if you haven't had that type of kind of persistent neurological kind of obsession towards something that is harming you, and that's not in your best interest. If you haven't really experienced something like that, it really is hard to understand why can't you just not stop. So you really have to really kind of hold their hand a little bit and kind of appreciate where they're coming from. But most of the time, because it works, I mean, that's the other thing, most of the time it works, of course. And I think that's where the drinking log comes in. I think the drinking log is maybe even more helpful for just the people in the drinker's life, so that you can see that, yes, I'm still drinking, and still drinking a lot, even possibly, but I'm down, 32.3%, and the number of these extreme binges have basically been cut to zero, and that type of thing. So I think all of those things I just said really can go a long way. But ultimately, it's, it's kind of the proof is in the pudding. I mean, the person has to start improving before they will fully get on board.
Yeah, really well said. And I know, with Dr. Sinclair's clinical trials, it showed a 78% success rate. I'm curious, being in practice, what have you seen? I know you've mentioned it works. You've seen people, it work for the majority of people. What have you seen as far as the success rate in your uh, practice?
I mean, people mention that number, and I say that's probably pretty close to what the number is. It's something like that, where we, most people for sure, I can say with confidence, it's more likely than not to work. And then probably it's even a little bit more effective than that, where, I really expect people to achieve their goal. Now, it's a little bit tricky, of course, in the outpatient setting. I mean, they're or kind of in a non trial setting where you're controlling for various factors. It's hard to really know sometimes because let's say a person doesn't show up, like you never see the person again. Maybe they had kind of a Claudia Christian experience where very rapidly they reached extinction. Their goal was abstinence, and not only did they never drink again, but they never took another naltrexone again, something like that. And so they never show up. They, you see them maybe once or twice, and you just never see them again. And so you don't really know some of the outcomes. You don't really know, and some of the outcomes could be because they had a side effect, or they changed their mind about taking it and they wanted to try something else, or so there is some percentage of people you just don't know the outcomes, and you can say, okay, well, maybe that's 50-50, but even that is, you don't really know kind of the people that don't show up. So it's hard to get precise information, but again, the 78% sounds about right, because even kind of with that in the mix, you could say if I see 10 new people a week that start on it, I really would expect 7 or 8 within, some 6-month period to really have some substantial reduction in not just the behavior of drinking. Yes, we're going to see data that shows some percentage in the number of drinks per week, but we're really going to see and hear kind of descriptions of the drinking itself, the role it takes in the person's life, the amount of mental space it takes up. We're going to see that kind of recede into the background as well, so that the person just starts talking about things like, it's not the first thing I did when I got home, or when I learned that my wife was going on vacation, I started thinking about how much I could, these types of things. I mean, really just, or I never ever like not finish a drink, and it's amazing. I knew I poured it and then almost forgot it, and then the next morning it was half empty. That types of things where people just start recognizing that its grip is loosening. So it really is something like that. It really depends on, of course, there are lots of variables. I would say one thing that it definitely does take some patience, because a lot of times, especially because Claudia Christian's TED Talk is just so widely known, at least, kind of as an introduction to the Sinclair method. So a lot of the people who are coming to me, that's kind of their first exposure to it. And she had a response to it that was fairly rapid. It certainly is within kind of the range of responses we see, but I wouldn't characterize it as typical. So if people have kind of that idea in mind that they're going to replicate, exactly what Claudia Christian did, then sometimes they might be discouraged. So I'd say a lot of the success is about understanding that it is a long process. Or it can be that this is like 4 to 6 months usually.
Yeah, I totally agree. And that's one thing I do see with clients that I've worked with is, if they kind of expect an instant result or the month or two and they're still not where they want to be, it can be discouraging. But to have those realistic expectations that this is, going to take a while, I think it helps people to not be disappointed if they're not seeing really quick results. So, yeah, I
Mhm.
would say that's, it's really encouraging to see that in your practice you've seen the same success rate as he saw in his clinical trials. And I would say that as well. I'm curious, when do you see naltrexone and the Sinclair method not work for people?
Yeah, so of course, yeah, it doesn't always work. And unfortunately, like I was saying, a lot of times when it doesn't work, we don't necessarily get good feedback on it because the person just decides to show up. And of course, we try to follow up, and people who don't make follow-ups or miss their appointments or something like that, we try to get to the bottom of it, kind of what went wrong. I'll talk about side effects in a second, or kind of adverse reactions, because that certainly is one kind of reason why a person might not have success with it. But and just, I would say the main thing is just taking it exactly as prescribed. Despite the simplicity of it, you're going to take this buzz blocking medication before you drink. It really is hard to be perfect with that. That something short of perfection might really kind of prevent it from working. Prior to drinking, you really have to have this adequate blockade 100% of the time. And we know that in medicine, just generally speaking, that's a very hard task, whether it be a multivitamin, whether it be recommendations from a dentist to floss daily, or whatever it might be. I mean, it's hard to really consistently do that. So I definitely sympathize with people who occasionally miss doses or what have you. So we really focus a lot on trying to have strategies to minimize that. So that's the one type of kind of thing. Why it might not work is because, in some sense, it doesn't ask much of a person other than to be perfect in this very kind of specific way. The other thing is the person might just simply not be able to take it due to tolerability issues. It's not that common that someone just kind of flat out could not take it at some dose. Usually, there have been situations where we've had to have it compounded, get it to a compound pharmacy and really get a small dose of it, which they're actually more, because low dose naltrexone, which is that's not related to the Sinclair method as such, but because that has become more kind of common treatment for types of like inflammatory pain conditions, things like that. So it's pretty easy to get it compounded at a pharmacy now. So a lot of times we can start at lower doses, but people do have intolerable gastrointestinal side effects, nausea, vomiting, diarrhea, something like that, or other kinds of adverse reactions. One of the things that's interesting too, it's kind of wild to think about, but naltrexone, most of the manufacturers of it, I think there's only one, and I think that they may have not even exist anymore, but they all contain lactose, like as an inactive ingredient. So a lot of times, it is important to know if you're lactose intolerant, because, especially if you're really hypersensitive to lactose, because the inactive ingredient in naltrexone is lactose. So that in that case, you would expect some type of GI upset that was really independent of the blockade of the opioid receptors. You definitely want to take it with a full meal, because we think of these kind of brain chemicals like serotonin, dopamine, in this case opioid receptors. All of those really are gastrointestinal in origin. Most of our serotonin, dopamine, norepinephrine, opioid, most of those receptors are in our GI tract, and that's why all of those really upset stomach's a common problem. So that can be a problem. I will say to that though, one thing is kind of the standard Sinclair method approach. If you read The Cure for Alcoholism, or just kind of even kind of the basic approach that we have, is that the first 2 days, half a tablet, half of a 50 milligram tablet with a full meal, not just food. But I even would say that maybe even a quarter of a tablet the first time. Most of the tablets, I understand, are pretty easy to break into a quarter of a tablet. And I would say that just because, most people don't need to do that. Most people don't even really need to do half a tablet, but you don't know if you're that person or not. So that's why we always really err on the side of caution. But I would say maybe even the first time, we could spare, maybe 5 to 10% of people by having just a quarter of a tab of the full meal this first time, with the idea that this is a long-term program. So kind of an extra day or two where you're not getting adequate enough blockade. I mean, that's a very, very small price to pay to kind of increase the number of people who are going to be able to take this. The other thing is sometimes medications don't work, whether it be a blood pressure medication, and we don't quite know. We're learning more and more about the way that particular enzymes are involved with the metabolism of a certain drug. And so I think that's going to be handy more and more. There's a company called GeneSight. There are a few of them, but for sure GeneSight that has naltrexone as part of their panel. And you can get information about how your specific your specific enzymes influence the rate of metabolism. So sometimes, let's say, for example, someone is a very slow metabolizer. In other words, they don't really break it down. So essentially, the level of naltrexone is much higher than you would expect. Well, then that person might have side effects, but really they could do very well with just 25 milligrams as a treatment dose. On the other hand, someone might be a rapid metabolizer, and they just break it down very, very quickly. In which case they would feel nothing maybe, and they would maybe need a 75 milligrams or a higher dose than average. So there definitely is that where you kind of have to, the vast majority of people are going to do fine with 50 milligrams, but there are some kind of underlying genetic reasons that they might be metabolizing it differently than average.
So fascinating. So do you see in the future perhaps people will be taking these tests to see, how quickly they metabolize naltrexone so that the dosage could be right for them?
Yeah, exactly. Especially, and really an insurance company, or especially if you're talking about scale, the types of information you get for one person it can be beneficial. It kind of takes it makes it a better educated guess. In other words, the odds are slightly more in your favor. But if you're talking about, like, say, an insurance company that has 10,000 members, or a hospital that has thousands of admissions, and you do this type of testing across a large population, then you're really going to see that that it really can make a big difference. There are certain SSRIs, which are like Prozac and Zoloft and these types of meds for depression and anxiety. Certain people have the way their enzymes, it's just not going to work for them. I mean, it's just a complete waste of time to prescribe it. Or they're very, very slow metabolizers, and if you start them at the normal dose, they're going to, be vomiting or whatever. So, if you knew that, then you wouldn't have to go through this whole sequence of types of things. So, but that for sure, I think it seems inevitable that it would just be almost kind of a standard medical thing that you have here, these DNA tests, and they tell you, right now it's really about kind of the rate of metabolism. It tells you kind of, are you a normal metabolizer? Do you have these particular enzymes that are associated with efficacy or not? But I think more and more you will see that it just really, instead of going through 3 or 4 different antidepressants, you can make it 1 or 2 with this type of information, something like that. Like, you improve the situation. And probably, who knows? I mean, one of the kind of things about naltrexone that is often talked about is the fact that it is generic, and that there aren't kind of financial incentives to find out certain things about it that there might otherwise be. But if you think of say something like antidepressants, they are different. Like, say, SSRIs, like Prozac and Zoloft and Paxil and Lexapro. Those are the common ones. They're essentially, we say, well, there's one particular way they work, but they are slightly different. There are variations on the same theme. And some of them work for some people, and some, so you could find something like that, where you have these opioid antagonists, like naltrexone, but it's slightly different. It's slightly metabolized in this particular way, or the way it, its obstruction of this particular receptor is slightly different in that it, translates into some percentage of people working in a different way. So that's one thing, is that we only really have, I think at some point, if there is some financial incentive to do so, we might have several variations on the same theme. And then that small subgroup of people who, it's currently not working for, we will be able to kind of bring them into the fold as well. But the basic idea that we need to block the reward for this, I mean, that's just going to be true. And then it's just finding these kind of safe chemical ways to do that.